It is my great pleasure to introduce Dr. Keith Sigel. Dr. Keith Sigel is Associate Professor of Medicine and Division of General Medicine, General Internal Medicine at the Icahn School of Medicine at Mount Sinai. Dr. Sigel is a member of the Mount Sinai Junior Faculty. I don't think now it's junior anymore. He is an Associate Professor in the Division of General Internal Medicine. He is a clinical researcher and epidemiologist with a primary research interest in clinical factors related to abnormal biology of lung cancer and anal cancer in patients with HIV. His clinical interests include issues associated with the care of aging HIV-infected patients and the treatment of hepatitis C co-infection. He has served as a primary care physician for the patients with HIV since 2009. Dr. Sigel received his bachelor, Master of Public Health, and medical doctorate degrees from the University of North Carolina at Chapel Hill, and his PhD from the Icahn School of Medicine at Mount Sinai. He completed his internal medicine residency at the Mount Sinai in 2005, serving as a chief resident, and went on to complete fellowships in general internal medicine and infectious disease at Mount Sinai. He directs Dr. Sigel also directs the Cancer Corps for the Veterans National HIV Cohort. He is a member of the executive committee of that cohort, and he is currently the principal investigator of 2 NIH funded studies. I have to tell you that it's not common, it's rare to find a brilliant clinician and scientist at the same time, and that's what actually characterized Dr. Sigel here. He has been really dealing with a lot of cases of COVID-19 through his work at Mount Sinai in this very important period of time. And if I keep introducing Dr. Sigel, I think will take hours to just mention his accomplishments to the patient's care and to the science. So without further ado, I'd like to introduce him to speak about COVID-19 or SARS-CoV-2 clinical issues. Dr. Sigel.
Yes, thank you so much, Khaled. And it's really nice to be here to present my experiences and my perspective on the literature to you guys. So I wanted to start with a couple of cases, actually. These will be brief. So in April, I served on the wards at Mount Sinai as a general medicine hospitalist. So a patient, and unfortunately this case is not too unusual. This is a 58-year-old man with no past medical history, taking no medication. He's a non-smoker, had run marathons, who came into our emergency room in the first week of April. His major complaint was actually nausea, but he was also having fever, cough, and shortness of breath. He had not traveled. His family members had had a viral syndrome as well that was much milder, and he was concerned that this could be COVID-19. At the time, he was afebrile, but when he walked, his oxygen saturation dropped down to 90%. But he looked well. He had an abnormal lung exam, and this is his initial chest x-ray. So we see bilateral infiltrates consistent with a lot of what we've been seeing around that time in patients. His labs were significant for a markedly elevated C-reactive protein, increased ferritin, a little bit of increased lactate, and his nasopharyngeal swab for SARS-CoV-2 was positive. So he was admitted to the inpatient service. He was treated empirically for bacterial pneumonia, but also with hydroxychloroquine and azithromycin. And to summarize his course, over the next couple of days, when I took care of him on the floor, he had increasing oxygen requirements, starting out first on room air, then 2 liters of oxygen, and then to 5 liters just to maintain 90% oxygen saturation. But when I talked to him, he said he felt fine, just nauseous. And I said, I think you'll be going home soon. On the right, we see the trajectory of some of his lab values throughout the first half of his hospital stay. By day 6, he was now requiring a non-rebreather mask to maintain 90% oxygenation. And we consulted our team that was dedicated to experimental agents to see if he might be eligible for an experimental treatment. Also at the time, because his D-dimer was rising, we started him on therapeutic anticoagulation. By days 7 through 9, he now is requiring a high-flow nasal cannula with 100% oxygen. He was started empirically on steroids. Day 9, his respiratory failure progressed. He was intubated, put on a ventilator. This was his chest x-ray at that time. We now see much more extensive changes suggestive of ARDS. He was transferred to the ICU, was started on experimental therapy with stem cells. He went into shock, was started on vasopressors, was also given tissue plasminogen activator at that time, also empirically. The next 6 days, he received supportive care in the ICU. And on day 18, he was extubated and transferred to the floors, back to the floors, was slowly weaned from oxygen. And now, about 27 days later, was discharged home. In follow-ups with him at home, he's still requiring a little bit of supplemental oxygen at home, and his functional status has declined. He's using a walker to get around. In contrast, I want to tell you about another case. So this is case number 2, 20 blocks away from Mount Sinai. This is a 47-year-old woman, Manhattan resident, also a physician, who experienced 3 days of greater soreness and joint pain when running. On day 4, she complained of complete loss of smell and taste. And over the next week, there were no other signs or symptoms. At that time, she tested positive for SARS-CoV-2. By day 30, her smell had returned, but she had no other signs or symptoms during that period. And this is my wife, who I live with, and despite living with this case, I have been PCR and antibody negative. So it helps to illustrate some of the complexity of dealing with this disease. So the SARS-CoV-2 pandemic has been unprecedented. New important data is being announced every day. This presentation was created this week, and it's likely to be outdated by next weekend. We're seeing lots and lots of preprints that have not been peer-reviewed. We're seeing a lot of uncontrolled studies that make it very difficult to derive conclusions. So we have to do our best during these times. So COVID-19 is the disease caused by infection with SARS-CoV-2. As Nicolas showed us, it's an RNA virus, a beta coronavirus. It's interesting because this SARS-CoV-2 infects both the upper respiratory tract and the lower respiratory tract in many patients, and is highly contagious. As you're probably all aware, this was first noted, well, widespread in the press, was reported December 31st, several cases of a new pneumonia with unknown etiology in the large city in Wuhan. And from there, it really spread. It is felt now, though, that probably there were cases that had been recognized for the whole month prior to that December 31st case. So from there, SARS-CoV-2 infection spread throughout China, then throughout Asia to Europe, and really throughout the rest of the world. And now, currently, the US is the epicenter of the disease. And as of when I checked this morning, we've now had over 70,000 deaths in the United States from COVID-19 disease. And we're really still struggling to understand the spectrum of this disease, at least certain components of the spectrum of this disease. As the cases that I illustrated at the beginning, or presented at the beginning, illustrate, and as you've probably heard, there really is a wide spectrum of COVID-19 disease. So based on data from China, we think that really among cases where we know patients have been tested, we think about 6% of those cases are what we would consider severe, and I'll describe severe cases in a few minutes. About 14% have what we would consider moderate disease, and then the vast majority mild viral syndromes, which still, people can feel pretty bad with the mild viral syndrome of SARS-CoV-2. But then there's really probably a very large proportion of people who are infected with SARS-CoV-2 that have no symptoms. And getting a sense of the number of people that are asymptomatic and infected has been a real challenge. Well, why are we interested in that? Well, it's useful information for a lot of reasons. And the proportion of asymptomatic cases helps us to determine what the case fatality rate is. And if you look across the literature related to asymptomatic infection, the proportions have ranged quite significantly. Probably one of the best venues for studying the epidemiology of this disease is from the Diamond Princess cruise ship, where we think that most people were exposed. Their estimate of asymptomatic disease on that cruise ship was 18%, which differs dramatically from other larger antibody-based studies or PCR-based studies. Most recently, there's been a controversial preprint from a group in Stanford, which has been called the Santa Clara study, which has suggested that very, very high proportions of people are infected with SARS-CoV-2 and are asymptomatic. And that's, so if you go with the estimates from the Santa Clara study or compare them to these other studies, you get very wide estimates in the case fatality rate. And this Santa Clara study would actually suggest that the case fatality rate is around 0.2%, which is, really just higher than influenza, but not tremendously higher. In terms of diagnostic confirmation of SARS-CoV-2, we're exclusively, I'd say, using oropharyngeal swab testing with PCR. This is the most commonly used method for diagnosis. In confirmatory testing, the sensitivity of nasopharyngeal swabs or the upper respiratory tract, the sensitivity has ranged from 30% to 90%. I think most of us think that it's probably somewhere in the range of 70 to 80%. And, as Nicolas mentioned, we're now starting to see more and more antibody tests, so serologies to SARS-CoV-2 that are being used to identify recent infection with SARS-CoV-2. The clinical presentation of COVID-19 disease is quite varied. However, the most common symptoms really are fever and lower respiratory symptoms, but I would say not everyone that is symptomatic with SARS-CoV-2 has fever or cough, although the majority do. One of the largest early studies was from China, published in the New England Journal of Medicine, and we see in this table the relative proportions of patients who tested positive for SARS-CoV-2 and they're presenting symptoms. Early in the pandemic, I was counseling patients that if they had upper respiratory symptoms, that they were less likely to have SARS-CoV-2. But in most series, we do see upper respiratory symptoms like congestion in up to 5% of patients. So it does not rule out this disease. Gastrointestinal or GI symptoms are quite common as well. In this series, nausea, vomiting, diarrhea we're seeing in about 5% of patients. But if you look in other series, particularly from China and Europe, you see greater prevalences of GI symptoms, diarrhea, nausea, vomiting. And if you remember the case from the beginning, nausea was very prominent in that case. We're also seeing increased recognition of neurologic and thromboembolic presentations, including myocardial infarction as a presenting scenario. So we're seeing very, very wide and heterogeneous clinical presentations. But again, fever and cough are without a doubt the most common. Now, I mentioned earlier how we risk stratify, sort of broadly risk stratify COVID-19 disease. And sort of the broadest categorizations we consider mild, moderate, severe, and then what I call critical. And this slide is really my own sort of personal creation. I'll give you something that maybe is a little more directly evidence-based in the next slide. But I typically consider patients that are mild that don't require any supplemental oxygen to maintain good oxygenation. Patients that are moderate is any patient that does require at least a small amount of supplemental oxygen to maintain 90% oxygenation. Where severe cases, I would say are patients that require more than 2 liters per minute of supplemental oxygen. And then the critical cases are cases where patients require non-rebreather masks or high flow oxygen, non-invasive ventilation, and mechanical ventilation. Now, oxygen supplementation is certainly not the only way to risk stratify patients with COVID-19 disease. This just happens to be what I consider a convenient, quick way to get a sense of severity. One of the earliest severity scales that's broadly available was developed by one of the Italian groups. It's called the Brescia COVID Severity Scale, and it's available online, very easily. This uses sort of broader pulmonary criteria for defining the severity of COVID-19 disease, and their algorithm actually also gives sort of concrete recommendations on management for patients that meet these different severity criteria. There are other scales of COVID-19 disease severity that incorporate biomarkers, that incorporate other clinical signs, and I would say that there's not still a gold standard. The natural history of this disease, there's a few, I think, important points to note. This is from one of the early-ish Lancet papers, also looking at a relatively large case series from China, and they illustrated the natural history of COVID-19 disease in patients that survived and comparing patients that did not survive. And the main reason that I bring this up is just to point out that we typically have this period, this first week, where we don't see marked severity of disease, of clinical disease. And then there's this period around day 7 to day 10 where patients typically worsen. So, and this was a pattern that I feel like we saw a lot in our patients as well, and was illustrated in the case that I presented at the beginning. You have patients that feel sick enough to come to the hospital, and they kind of hang out for about a week requiring some oxygen, and then really take a turn developing an ARDS-like syndrome, and then multi-organ failure downstream of that. This is another illustration of the natural history of disease in terms of clinical manifestations. And again, we see this asymptomatic period, then a period which seems to typically last for some patients about a week, where there's mild to moderate symptoms, including fever and cough. And then we get some of the manifestations of this cytokine release syndrome, where patients that develop it have hyperinflammation and organ dysfunction, most prominently pulmonary dysfunction, but also can be renal failure and shock, neurologic consequence. And the patients that don't resolve from any of these earlier phases die. One issue that has become more and more prominent, although I think has been recognized since the very beginning, is hypercoagulability. Particularly in severe cases, and sort of later during the hyperinflammatory phase or the cytokine phase, we're seeing increases in thrombotic events, and these are both micro thromboses and macro thromboses. in patients' labs, we're recognizing elevated D-dimer. D-dimer is a biomarker that we've been following in these patients for quite a while. But we also see increased prothrombin time and a decrease in fibrinogen. This has prompted use of tissue plasminogen activator and therapeutic anticoagulation in a lot of patients. But I'd say that discrete guidance for use of these therapies is still somewhat unclear. And in the last 2 weeks, this is actually a series from Mount Sinai of 5 cases of patients that were younger than 50 that presented with strokes, with cerebrovascular accident as a complication of COVID-19. And we are also, and I think most centers are seeing increased proportions of patients with large PEs in severe COVID-19, much greater prevalence than would be expected. Nico talked about the immune response. Just briefly, it does seem that a successful immune response involves innate immunity as well as cell-mediated and humoral immunity. One thing that I think is interesting in some of the epidemiologic, translational epidemiologic literature is that it seems like there may be some evidence of cross-reactivity to other beta coronaviruses in patients that have milder disease course. And also that mild cases, and I don't know that the jury is necessarily out on this, but that mild cases seem to have lower antibody responses, which leads us to question whether or not, in patients that have been infected, whether or not antibodies are always going to be measurable. You know, I think one of the best studies to date of the trajectory of antibody response was a preprint from this week that came out of Mount Sinai, looking at a very large cohort of patients that had definitive confirmed COVID or SARS-CoV-2 infection, and we're seeing IgG responses that really seem to start around day 7 after infection, and that probably the most optimal time to test people for IgG is around day 21 after clinical symptoms begin. In terms of laboratory testing, we're getting a lot of labs on these patients, and we see disturbances in elevated CRP, elevated D-dimer in severe cases, procalcitonin, ferritin, LDH. IL-6 seems to potentially be a biomarker that we can use to identify cases that are going to have a more severe course that may potentially prompt intervention. This is from from nearly 2,000 patients at Mount Sinai. I would say as of yet, there's no magic biomarker or combination for predicting who is going to do, that really risk stratifies well. As you can see, these curves separate, but they're not massively separated, and that we still need a lot of work to predict who's going to do poorly. This is looking at population-based data in terms of death rates from coronavirus stratified by age. And just to illustrate that, as you've probably heard or been aware, children seem to have very low morbidity from SARS-CoV-2 infection. In terms of things that predict poor outcomes, a preprint that's less than a week or 2 old from the UK, using a very large data set, found that the strongest risk factors were increasing age, male sex, obesity, diabetes, hematologic malignancies, and organ transplantation history. Interestingly, hypertension was not significant in their analysis, and I'd say this is largely consistent with what we're seeing in New York. In terms of management, patients with mild COVID-19 do not require hospitalization typically. In my personal experience, I'd say that probably one of the worst signs is a patient that has, in front of you has increasing oxygen requirements, particularly patients that go from needing a liter or 2 of oxygen to more than that. That seems to be a very high risk sign. Now, in terms of drug therapy, no treatments have been currently advocated by the NIH consensus panel, the US NIH panel. Most commonly, we're using hydroxychloroquine and azithromycin in the face of not great data. There's numerous investigational agents, and we're now starting to get some RCT data. These tend to be direct antivirals and immunomodulatory therapies, but there's also a lot of complementary therapies that we're using, including steroids and anticoagulation. Hydroxychloroquine and azithromycin, there now have been at least 8 major studies, of which really only 1 or 2 are randomized trials. None have shown any significant signal towards efficacy. This is from the Chinese RCT that was published, well, that was preprint maybe about 3 or 4 weeks ago, that really didn't show any major benefit. This past week, there was a large observational study from Columbia University that also showed no benefits to hydroxychloroquine. However, this was observational and had some risk of bias. Remdesivir currently probably has the best, questionably, data. There was an uncontrolled case series in New England Journal that showed 68% of patients with severe COVID-19 improved. An RCT that was published in The Lancet about a week and a half ago that was stopped early because of enrollment issues was non-significant for benefits, but the US NIH has a very large trial and has preliminarily announced that remdesivir has been associated with 31% faster recovery. So remdesivir seems to be rolling out in a much wider way. There's been a lot of interest in Tocilizumab, which is a monoclonal antibody to the IL-6 receptor. Again, this correlates with what I showed you earlier about high IL-6 being associated with severe COVID-19. There's several ongoing trials, and the French have announced in a press release from a randomized trial that Tocilizumab improved clinical outcomes, but there's no published data yet. Lopinavir ritonavir has also received interest, but in a randomized trial from China in severe COVID-19 did not show any benefit. Also, we've been using a lot of convalescent plasma antibodies from patients that have recovered in New York, but we don't have any controlled data. Steroids are not currently advocated by guidelines, but they're being used out of a lack of other options. And therapeutic anticoagulation is also being widely employed. This is from Mount Sinai data just from this past week in Journal of American Cardiology, showing, again, in observational data, that patients that received therapeutic anticoagulation had better survival. One thing that's also being widely employed is proning, which was a technique that was developed for improving oxygenation in ARDS patients. And there's a published series showing that it's improved hypoxia. This is in non-intubated patients. And just another observation is that diuresis often seems to be appropriate for ARDS related to COVID-19 patients. So careful fluid management has also been advocated. I just want to go over some, in my last couple of slides, some outcomes that have been reported. This is from a large cohort in China. The adverse outcomes related to COVID-19 disease. And just to illustrate, we see in that large cohort, which included both moderate and severe patients, their rate of mechanical ventilation was about 6% and death was 1.4%. Italy reported a much higher death rate among patients that were PCR positive of about 8%. The New York experience has been maybe a little different, although we're looking just at hospitalized patients. The first large paper from a New York health system was from the Northwell system in over 5,000 patients. Their death proportion from COVID-19 was 21%, but they didn't tell us anything about the COVID-19 severity at presentation. And from the Mount Sinai Health System, this is in preprint, at 5 of our hospitals, we find a death rate in hospitalized patients of 17%. And this is just to show throughout the month of March, our hospitalization rates. Just quickly, COVID-19 in special populations. Since the outset of this pandemic in China, it's clear that severe disease impacts certain groups more. The key morbidities, as I mentioned, are obesity, diabetes, and cancer. We're seeing worse outcomes in patients with organ transplantation. This is data from a Chinese matched cohort looking at patients with cancer. Their risk of adverse outcomes was nearly double compared to patients without cancer. And this is unpublished data from Mount Sinai, looking at patients with HIV that we've got under review. We're actually finding no difference in the risk of death in patients with HIV. COVID-19 survivors, there's been, we're starting to see reports of the long-term impact. It's likely we're going to see long-term decreases in pulmonary function in severe cases. We're seeing post-COVID cardiomyopathies. Guillain-Barré syndrome has been reported. Male fertility as well. And most recently, this has gotten a lot of press recently, this Kawasaki-like syndrome in children. There's been 2 deaths in New York now reported. So thank you so much, Khaled, for organizing this talk. I'm going to put my slides on my Twitter account in the next hour if anybody wants to use them locally.
Thank you very much, Keith. This was very informative lecture and very useful for everybody. I'm a radiologist and I loved it a lot. So this means that the general population will like it. So this is fantastic.